Welcome to Group Three's presentation on healthcare policy and the potential implementation of universal healthcare in the United States. Our group, Allison Ford, Candace Fuller, Eleanor Pear, Zach Hendrick, and myself, Tiffany Williams, analyze key challenges in the current U.S. health system and what a universal model could change. Despite under the Affordable Care Act, nearly 30 million Americans remain uninsured and major disparities persist across income, race, geography. We examine policy options, cost, and operational considerations, as well as lessons from other countries that have adopted universal care. Each group member will highlight a specific part of the analysis, from access gaps and public health impacts and political feasibility and budgeting. Our goal is to offer a clear, balanced perspective of what a universal healthcare could mean for the United States.
Hey, I'm Allison. Our policy area addresses the lack of universal health care in the United States. The problem is about access and equity. Nearly 30 million Americans are uninsured. Our current fragmented system leads to three major impacts. The first two are public health and quality of life. Lack of universal coverage means people delay or forego essential care. When timely intervention is skipped, preventable conditions worsen, leading to higher rates of morbidity and mortality. This disproportionately impacts communities based on income, race, and geography, widening vast health disparities across the country. The third is economic stability. High out-of-pocket costs are a national crisis. Medical bills are the leading cause of personal bankruptcy and result in crushing medical debt for families. Sheer inefficiencies in our multi-payer system, all the billing, coding, and marketing, add administrative waste that drains our economy and ensures we pay the most for the worst outcomes. The lack of universal coverage is a persistent drag on our public health, our family finances, and our national economy. Our policy analysis will now focus on finding a feasible solution to this systemic issue.
A universal healthcare policy centered on a single payer or robust public option would ensure that every individual has access to essential health services regardless of income or employment status. The primary objective is to reduce financial barriers by eliminating out of pocket costs for basic care and pooling resources through a government administered system. This model would promote equity by guaranteeing that all citizens, urban or rural, insured or uninsured, receive the same standard of care. Funding could come from federal and state budgets, payroll taxes, or income-based premiums, distributing costs fairly across the population. By consolidating fragmented insurance programs into one streamlined system, administrative inefficiencies would be reduced, freeing resources for patient care rather than paperwork. Ultimately, this approach would make healthcare simpler, more efficient, and universally acceptable, creating a healthier, more productive society where no one is denied care because of cost or circumstance.
To guide our analysis, we used several key framing questions. We first looked at the policy lever and level of authority, noting that any major reform would require federal legislation, with states handling much of the implementation. Operationally, universal coverage models typically rely on mandatory enrollment, tax-based funding, and administration through agencies like CMS. We then considered the main objectives: expanding access, improving equity, and controlling long-term costs, supported by ongoing data showing millions remain uninsured. We also accounted for legal context, including ACA and potential court challenges. Finally, we reviewed international examples like from other countries like Canada, the UK, and Germany, which shows that universal systems can improve with outcomes with reduced costs. These questions help structure our overall evaluation.
Our analysis next focuses on the public health impact of implementing universal health care. This involves assessing the potential magnitude and distribution of benefits. A universal healthcare system directly addresses the problem by increasing access and reducing financial risk. By eliminating financial barriers, we shift focus from costly emergency interventions to preventative care and early disease management. This change directly improves morbidity and reduces mortality. This is essential to contain the epidemic level of chronic diseases currently straining our economy and society. The reach and distribution of this policy is entirely equitable. The primary beneficiaries, the uninsured, low-income, and rural populations, would see the greatest gains. Universal coverage guarantees that health is treated as a right. A transparent analysis requires noting the negative impacts, specifically the potential for tax increases and transitional challenges for providers adapting to new payment models. Also, data gaps exist regarding accurate long-term system cost and utilization patterns, which will require continuous evaluation. Ultimately, this policy creates a more resilient population by ensuring health services do not expose any user to financial hardship.
The political feasibility of universal health care in the United States remains complex and contested, shaped by decades of polarization dating back to the Truman and Clinton eras. Efforts to expand coverage face strong ideological divides over the government's role in healthcare. Supporters, including public health advocates and labor unions, argue that universal coverage promotes fairness and efficiency, while opponents, such as private insurers and pharmaceutical companies, resist reforms that could threaten profits and market control. Social and cultural factors also pose challenges. Persistent knowledge gaps, fear of systemic change, and many Americans' preference for employer sponsored coverage weaken public consensus. However, cross sector impacts could shift attitudes over time. Universal healthcare may enhance labor mobility, improve economic efficiency, and reduce the administrative burden on businesses. Yet, balancing these potential benefits with concerns about private industry disruption continues to make large scale reform politically difficult.
When we assess the operational feasibility of universal health care, the central question is not if the concept works, but how we manage the huge administrative transition. First, resources. Successful implementation requires a massive expansion of the healthcare workforce, extensive information technology, system modernization, and centralized integration. The entire scheme must effectively be governed under a federal body such as the Centers for Medicare and Medicaid Services. Administrative capacity is the system's backbone. Second, the timeline. This cannot be a quick change. We envision a phased rollout, 2 to 4 years for legislative enactment and initial structuring, followed by a 5 to 10-year phased implementation. Third, scalability. This gradual approach allows us to test models through essential state-level pilots before attempting national deployment.
A U.S. universal healthcare policy, especially a single payer model, would significantly reshape national budgeting. Estimated to cost $32 to $40 trillion over 10 years, it would require major federal revenue changes through new taxes or redirected spending. Yet long-term savings are likely. Single-payer studies show 10 to 15% reductions in national health spending from simpler administration, lower drug prices, and fewer profit-driven inefficiencies. Universal coverage also encourages earlier diagnosis and preventive care, reducing costly emergency and chronic disease treatments. A healthier population strengthens the workforce and eases pressure on public programs. Though the transition is expensive, potential economic benefits could improve long-term fiscal stability.
When considering policy options for universal health care, I think there's two approaches that work best. The first one being the single-payer system, meaning that the coverage is going to come directly from the government. This one provides the highest amount of coverage, but I do worry about potential political hurdles that must be cleared and the high upfront costs. The second option is the public option. While this one doesn't provide as much coverage, I do think the lack of political hurdles is very, very positive. And personally, I think it's always best to have resources and coverages coming in from multiple different places instead of having to rely solely on the government. That way, if something happens, you have another source of coverage to kind of help offset that until things return to the way they should be. When starting the implementation process, there are several key things that I feel must be done. And, the first one is to just engage the stakeholders. Obviously they have a lot riding on the policy and the results of it. And so I think it's wise and smart to make them feel involved and to show them that you care. And the next one would be public education campaigns. This is basically just teaching the people what the policy is, what it's going to do, and how it's going to benefit them. This will build up a certain level of trust with them as well. And then the next one being pilot programs, in certain areas. This again shows how it can be effective, but then it also allows you to see the program and see what adjustments you can make to make it better for everyone. And then legislative strategy, just linking your performance metrics to the funding so that you can make sure spending is going the way that it's going to and you're getting the most out of it. And then the last one is, just oversight to make sure things are running smoothly, as efficiently as possible, and then to have some level or a high level of accountability for everyone to ensure they're doing what they're supposed to be doing and not creating more work for others and wasting time and resources.